I'd like to introduce our second speaker, Dr. Eric Turcotte, who's an associate professor at the University of Sherbrooke and clinical head of the, I'm just going to get this straight, of the Sherbrooke Molecular Imaging Center, which is really a huge research center, and particularly in the area of PET imaging. Sherbrooke is a center where we sent all our patients for PET scans before our own PET scanner opened up here. He's also president-elect of the Canadian Association of Nuclear Medicine, and he's going to be talking to us about novel radioisotope therapies for neuroendocrine tumors.
Thank you very much, and good morning. So I would like to give you a small glimpse of my work I'm doing in Sherbrooke about nuclear medicine imaging, about PET scanners, about potential therapy for neuroendocrine tumor. And I will invite you to a trip into the Star Trek field of imaging in Canada. So first I would like to introduce you to PETscan. So PETscan refers to positron emission tomography. That's a new kind of imaging technique that appeared in Canada since 1998 into the clinical, but we were using it for research many years before. And since 1976 that we are using PET scanners. And the main idea about that technology is a technology that is able to measure the physiological process with short-lived isotopes such oxygen, nitrogen, carbon. And of course, those are all atoms that we may find in any kind of molecule into the human body. So why PET? First, because it's a non-invasive technique. You do an injection, and that's all. There is nothing that will touch the patient or create damage to the patient. Second, PET is quantitative. So we are able, with that technology, to measure the expression of the disease, the intensity of the disease, the intensity of the receptor. It's very fast. We are talking now of scans about 25 minutes for a whole body scan. It's very sensitive, sensitivity about tumor of 3 to 4 millimeters. That's very, very impressive. And the advantage of PET is just because the metabolic and biologic change in a disease always appear before any anatomic change. So with the PET scanners, we are not waiting for the tumor to have 3 to 4 centimeters before being diagnosed. We are able to find it very quickly when it's about 3 to 4 millimeters. So it's more sensitive than CT, than MR, and of course from echo. The other advantage of PET is the injected dose is at pico or nanomolar quantity, so it's like homeopathy for the tracer. There is no biological effect at all with those tracers, because we would like to avoid any interference with the biological process we want to measure, because we want to stay quantitative into assessing the disease. But the main inconvenience is we need a very expensive setup to do PET images. And it starts with the cyclotron. So a cyclotron may cost 2.5–3 million just for the cyclotron. You add to that 2 million for the bunker, for the shielding to protect the staff around the cyclotron, and all the radiopharmacy. We are talking about millions of dollars just to have the cyclotron. You are seeing right now the cyclotron from Sherbrooke that was installed in 1998 and still working actually. And those kind of cyclotron may last 20–25 years without any problem. And there is no uranium inside. So for the health and the protection, it's very good. And it's able with that to produce the short half-life isotope. So the concept of half-life is the time it will take for the radioactive tracer to decay of 50%. So if I'm saying a half-life of 10 minutes, so if into my vial I have a certain amount of activity into it, and I wait 10 minutes, after 10 minutes I will just have 50% left of the initial radioactivity. And 10 minutes later, it's 50% of the 50%. So we are always losing the radioactivity inside the vial. And that's why we need to produce it every day, so for each patient. This is again the cyclotron. You're seeing right there the targets where the radiopharmaceuticals are made. We are using tubing across the floor, across the wall, and we bring every radioisotope into a clean room. So a clean room is a special room that is accredited by Health Canada to be pathogen-free, no dust. It's a very sterile environment that we may use to create intravenous drug for human use injection. You're seeing actually the staff putting a gown, so just the eye are exposed to the air. Everything is protected. We want to protect as much as possible the final product to be as sterile as possible. Because we are playing with radioactivity, Those cabinets are all shielded with lead, very, very heavy. It's impossible to move them when it's installed. You're seeing, because we are using very intense radioactivity, everything is controlled with automatic synthesis unit. It's not handmade. It's controlled by computers. So we care about the staff. We don't want to expose them to any kind of radiation. So the staff, actually the technician is programming the computer. The computer do the job. 25 minutes later, we have the radioactive tracer ready to be injected to a patient. You will see actually the technologist at the last unit with the filling unit. Everything is robotized again. And according to the center that the vial should be delivered, we put into the amount of radioactivity need to operate the whole day for that center. And we are doing that each day of the year, 375 a day. And then that we have the radio tracer, we need a special camera. So we can't use the regular spec camera that are readily available across Canada. We need PET scanner. That's the only technology that is able to deal with that kind of isotope. And we're talking about investment of about $2 to $2.2 million just to have that kind of camera. Across Canada, there is 31 PET scanners. 50% of them are in the Quebec territory. All the PET scanners available now since 2005 are hybrid cameras, so we are able at the same time to perform a CT scan. It's a whole body CT scan and then followed by the functional molecular imaging with PET. So it's possible in 25 minutes to have both exams at the same time, and then the computer will show you and show us very beautiful images with the very specific anatomy, whole body anatomy. We are using 5mm slice. We can go with 1mm slice. You have the functional activity obtained by the PET scanners, and then we fuse the anatomic over the functional image, and that create the fusion. And that's how we operate each day to detect cancer for many patients across Canada. We have many targets because we need to, many different cancer may have different targets, and one tracer is not good for all cancer, and that's still true for this kind of technology. The most useful tracer right now is FDG. FDG is a glucose analog because we know that the human body uses glucose to function, and because cancer needs more glucose for proliferation, we are able to catch those cancer cells just by the glucose uptake, so the FDG uptake into that cells. I'm showing you here the other kind of targets that we may use, like amino acids. For the neuroendocrine tumor is, of course, the Lu-DOTA peptides that may be used. FLT for cell proliferation, FES for breast cancer, and annexin for apoptosis. And all the ones in red are actually available in SureBook, either as a clinical trial or under a preclinical trial. So those kind of tracers may be used to give answer about specific disease right now. So in oncology, the main indication is really FDG. We are using it a lot of time for initial diagnostic, staging, restaging, response to treatment, and follow-up. I will show you as an example how we perform the exam. So I present you Esteban. Esteban is one of the technologists in SureBook. He's actually in the hot lab where we store the radioactive tracer that we use for images. So Esteban, to protect himself, will put the syringe into a specific shield for that syringe. Esteban wants to have children, so he will use all the possible shielding around him, a glass shield and a shield pot and everything. So he put a small amount of radioactivity into the syringe, and now we'll check into a dose calibrator. That's the only way to measure the radioactivity into the syringe. And when it's done, we know exactly that the amount of radioactivity into the syringe is exactly what the patient needs. So Esteban put the syringe into that box, in the shield box, and during that time, another technologist, so it's a well-trained department, so this is Jocelyn Hans. She will put a needle, because this is the only invasive things that we are doing for the patient. Just one needle. And then we check the blood glucose level, because when we inject FDG, FDG is a glucose-like, so patients that are diabetic may interfere with the exam. So 5.6, normal. So Esteban entered the room, and we'll take the syringe and inject the tracer to the patient. So that's easy as that. There is nothing more to do. So the patient will wait for 60 minutes, and then we'll enter the PET suit. We put on the table, and we'll stay there for about 20-25 minutes for the scan without moving. We can't move though under those cameras. And just before leaving, the computer are now so fast that it's possible even to have the images and to do the diagnostic before the patient is leaving the department. So you're seeing actually somebody scrolling into a case. It's like a video game in 3D. We are seeking the cancer into 1,000, 2,000 slices of the human body, and we do the report. And it's working well. You may see here a patient with melanoma. So except the brain, that's normal to have a brain uptake because the brain uses glucose, and it's absolutely normal to have a bladder activity. But all the other hotspots into the body are metastasis from the melanoma. So it's easy like that to see where is the disease, where the disease spread. This is an example of lung cancer, and this is an example of kidney cancer where the whole kidney is cancer. And also you may see easily the metastasis into the lungs, into the bones, and everywhere. And what about neuroendocrine tumor? PETscan with FDG works well only with undifferentiated neuroendocrine tumor. And that's better than octreoscan, because when the tumor got very aggressive, they lose the somatostatin receptor on their surface, and then they will uptake the FDG. So the FDG is very good for thyroid medullary cancer, the Merkel cell tumor, that is a kind of neuroendocrine skin cancer, and the small cell carcinoma, the lungs or the prostate or any kind of small cell carcinoma. And FDG is worse for pheochromocytoma and paraganglioma, where MIBG is very much better. And when we are talking about well-differentiated tumor, octreoscan is better and FDG is not recommended for those patients. And that's very problematic because we need to scan more and more patients with neuroendocrine tumor because we discover over years more cases of neuroendocrine tumor. And the baddest thing is a lot of time we detect them for years without obvious sign or symptom for that disease. So the diagnostic is very late. So we need a tool to diagnose those patients very quickly in their disease. So we turn to the bench and we start asking questions. So which target is the most suitable for neuroendocrine tumor imaging with PET? And of course, we know that since many years with octreoscan, it's the somatostatin receptor. Those are surface receptor. They are easily to reach for a radiotracer. That's the best target for now and for many years to come. There is 5 types of somatostatin receptor. The one that is very interesting is the type 2 subtype that is almostly visible on all neuroendocrine tumor. But the good thing, it's also available on other kinds of tumor like lymphoma, breast cancer, thyroid cancer. So it's possible to image maybe breast cancer with the somatostatin receptor imaging someday. But we will see with the clinical trial. And for the neuroendocrine tumor, the status of receptor is very high for the type 2, like 100% for gastrinoma, leukodoma, down to 38% for the medullary thyroid carcinoma. So now that we know the target, we want to target the somatostatin type 2 receptor. We need a probe to image those receptors. The concept of the probe is always made of a ligand, so that's the key that will go into the lock, so into the somatostatin receptor. We need also a light to be visible into the human body for our PET scanners. So for the ligands, many ligands were tried for many years. You certainly are aware about DOTA-TOC, DOTA-NOC, DOTA-OCtreotate, octreoscan, octreotate, pentriotide. So many kind of ligand were used. And I would like to put you really the interest on the DOTA-OCtreotate, which actually is the most sensitive for the somatostatin type 2 receptor. Very sensitive, more than everything that was tried before. So we need to go on that field and on that trend with the DOTA-OCtreotate. as a ligand. And now we need a light to put on the DOTA-octreotate. The wall, actually, many centers in the world, like the one in Rotterdam, in Uppsala, or the Berka in Germany, are using Gallium-68 as the light to show the tracer into the body. The generator is made in Russia and then moved to Germany to be built. The generator is quite expensive. It's $35,000 for a year to use. And each time we are using the generator, the quantity of radioactivity the generator can give is very low compared to the number of patients we would like to scan for a day. And of course, the half-life is 68 minutes. So at each 68 minutes, I'm losing 50% of the tracer. So we need to be fast with it. And when we compare the DOTA-octreotate with the octreoscan, it's very easy to see that the DOTA-octreotate with PET is very much sensitive, more specific, more accurate than SPEC with octreoscan and even with CT or no CT. So this tracer is actually the state-of-the-art to image the neuroendocrine tumor. There is no question about that. So now that we can target tumor expressing somatostatin receptor, can we give radiation to the patient to destroy those cells? And that creates a new dogma into the nuclear medicine field that we now call theranostic. So it's now the time to translate the diagnostic probe into a therapy probe. And that's absolutely a new field in nuclear medicine that is expanding widely around the world. So why we would like to do peptide receptor radionuclide therapy? First, we know by imaging with Gallium-68 DOTA-octreotate that we can show a high tumor uptake with those tracer. And then we can perform a diagnostic scan with radio-level somatostatin and that can be used to identify suitable candidate for the treatment. And of course, the radionuclide suited for therapy are available. They are not on the Canadian ground, but it's possible to bring them into Canada. So how can we change from a diagnostic probe to a therapeutic probe? That's very easy. We just need to change the light. To change the Gallium-68, that's the light for diagnostic, to something else that is very intense and will give very localized radiotherapy for the treatment. And that's the idea of the PRRT. So we would like to introduce around the cell the analog, so the somatostatin analog with the treating isotope and to deliver locally lethal radiation to kill the cells that express somatostatin type 2 receptor. For the radionuclide therapy, we have many tracers available, like iodine-131 that will be used for thyroid cancer. We can use it also to treat with MIBG. But for the DOTA-octreotate, the isotope that are very interesting are yttrium-90 and lutetium-177. And the main difference between the isotope is the range of the radiation. So some of them may treat very largely, and the other one will treat a small field around the tumor. As an example, if you would like to treat somebody with indium-111 octreoscan, the indium-111 will deliver the radiation for about the cell itself. It won't kill the cells around. If you are using yttrium, because of the radiation and the path length of 12 millimeters, so the range of yttrium is 12 millimeters, you will kill a lot of cells in the path of the radiation. But of course, you will also kill healthy cells around. So that's why we would like to use more lutetium, because lutetium is just 2.1 millimeters for the maximum range compared to 12 millimeters with yttrium. So that explains why lutetium actually will be a best choice for those treatments. For the criteria for PRRT, so we are treating non-surgical patients with metastatic tumors, patients that have no response to medical therapy. Of course, we need radiosensitive tumor because the treatment won't work at all. And we need the patient or tumor that are expressing very clearly the receptor, so with a high affinity of somatostatin type 2 receptor with high density and a very homogeneous distribution. Those are 5 different cases done with Lu-DOTA-octreotate, and you may see easily liver metastasis, bone metastasis, gastric cancer, a huge liver metastasis right there. So the tracer is very good to show where is the disease and to show very clearly the extent of the disease. When we look into the literature, there is three groups that are doing research in that field. So the first one is the Rotterdam experience, so made in Rotterdam. They started in 2005. In 2005, they did 131 patients, very different kind of neuroendocrine tumor. They were using dosage not really clear, between 100 to 200 millicuries. And they did that for many cycles with interval of 6 to 10 weeks. And they got very interesting result. Of course, they got 47 positive results for the treatment. But if we look about the complete response, is only 2%. So this kind of treatment is not a treatment really to cure, but that's a treatment that will decrease the speed of the disease or will stabilize the disease. And in that series, actually, only 18% of the patient have a progression of the disease after the treatment. So you may expect to have a stable disease or a decrease in the size of the disease, but very rarely a total cure. If we look about the Rotterdam data, again, in 2008, where they increased from 131 to 321 patients, they're still having exactly the same result. So it's pretty clear that the treatment is very effective. In Uppsala, they did also the same kind of study, 56 patients, so that's very, very less. And they showed about 50% of positive result for those patients. And the biggest experience, of course, is from the Bad Berka, from a Richard Baum in Germany, that did actually 1,500 patients with lutetium and 1,300 with yttrium-90. So very, very impressive, very, very good data, and a lot of patients around the world visit Richard for those results. And again, that group showed an overall response of 50% after 3 cycles with that treatment. So the 50% seems to be the magic number for doing treatment with lutetium and octreotate. And also Richard showed really an improvement of clinical symptoms in 85%. 75% of the patients decreased their dose of octreotate after their treatment. 95% got a weight gain of 5%. And there was, of course, an improvement of health status for every patient. This is an example for a patient with a disease in 2006, in March, received a first cycle. 3 months after the first cycle, the disease decreased a lot. Then they redid a second cycle, and after the third cycle, you may see 6 months after, there is no residual disease in the patient. So this is one of the examples that got a total cure with that treatment, and that patient still under remission until August 2010, and we don't know yet if the patient relapsed, but that's very, very good to see a metastatic disease like that in 2006 and to have no relapse in 2010. So that's a positive point to keep in mind. Now, what about the Canadian perspective? My favorite point. Okay, in Canada, we are very good in imaging. We are imagers. We were the world leader in isotope production with the Chalk River reactor in Ontario. We may produce across Canada isotope with cyclotron. We have many cyclotrons already in place and more to come. We have an increasing number of PET scanners across Canada, and many physicians in the ground are pure nuclear medicine specialists. So they are working really in the field of nuclear medicine. But the main problem for imaging is that we have no research molecular imaging network to support a pan-Canadian clinical trial. What about the therapy now? Okay, we are at the bottom end of the therapy. There is no many center doing therapy. Some in Edmonton, London, Ontario, Montreal, St. Luc, and some occasional center, but it's nothing compared to the biggest series from Rotterdam or from Bad Berka. So we are very far to get into their ball game. And again, there is no research molecular imaging network to support a pan-Canadian clinical trial. And many patients are sent overseas to receive those treatments, and that's an unacceptable situation. About the imaging network, we are waiting actually the approval of a $10 million CIHR initiative to create a molecular imaging network. There's an oncology group, cardiac group, and neurology group. And about the oncology, I am the co-chair with François Bernard and Sandy McEwen. And the concept we would like to implement into the imaging network is one chemistry across Canada, one voice in front of Health Canada, centralized core lab, and multi-centric study across Canada. So that's the main idea behind the imaging network, and we are still waiting the approval of that. I hope it will be a positive result. And of course, we need a registry to elaborate diagnostic procedure for initial staging, to standardize treatment across Canada for which kind of treatment is the primary, secondary, tertiary. We need to elaborate follow-up procedure. And why that is because it's very much easier to define a specific treatment when a consensus across Canada is made. So if we are trying to create protocols from province that may be different from the other province, we are going nowhere. We are doing research, but because we are not speaking together, we'll have results that will not create that can be deployed across Canada. For the source of octreotate, I can tell you right now that we are producing in Sherbrooke Lu-DOTA-octreotate. So we have Lu-DOTA-octreotate in Canadian ground, so made with our radio pharmacy, so that will be much easier to place that molecule in front of Health Canada for CTA approval. And actually we are filling the CTA to go into clinical trial with that molecule. Here we're just saying this is a small rodent, just to show you because I'm not allowed right now to do human. But this is actually a rodent that had the Lu-DOTA-octreotate, and you're seeing the intense uptake here in the pancreas. So that's a very good tracer. We have the Lu-DOTA-octreotate on Canadian ground. There is no problem for that. About the Gallium-68, for me, I think it's a problematic tracer. Even if the wall actually are looking about that kind of generator because they don't have access to a cyclotron, the situation here in Canada is different. If you have to place a generator that costs $35,000 at each PET centers across Canada for doing a few patients, I think that the administration will say no. Try to pull your patient somewhere and do your scan. But my idea is I would like every center across Canada to be able to scan that disease because it may be important first to see the extent of the disease for the patient, to see if it answers to the response to therapy, but I would like that tracer to be available for diagnostic, so well before the disease is really visible on the clinical side. And that's why we need the molecule everywhere across Canada for the day that somebody thinks, oh, maybe that can be a neuroendocrine tumor, that the tracer will be there and give the answer. And for that, I will have to change from Gallium-68 to another isotope. We are actually working in Sherbrooke to have an isotope of 3 hours half-life, and I think that will be in good shape for doing clinical trial across Canada with that kind of tracer. So that will be available more across Canada than the very specific center. And we will use the Sherbrooke GMP facility. So we are seeing right there all the things that we can do. So the products are made, are sterile. We have good discussion with Health Canada. We have many clinical trials with them. So it will be possible using our facility and our protocol to bring that molecule like the other one that we already present to Health Canada. And there is a team information actually in Quebec. So actually I'm like not really the president, but let's say the director or the facilitator of the team. So I will provide all the expertise from Sherbrooke for the probe development, to elaborate the human clinical trial, to talk with Health Canada, to have the license to do the tracer. We have also in the team radiochemists, because if you have a problem in clinic, so the radiochemist can be there to fix the problem into the molecule or to find another new molecule that may be more sensitive than the first one. Dr. Michel Picard from the Saint-Luc Hospital is very kind and would like also to start treatment in Montreal. We have Jean-Mathieu Beauregard in this room that is just returning from a training in Australia on Lu-DOTA-octreotate treatment. So we have actually right now in Quebec the expertise for doing that kind of treatment. We need a molecule. And we need also to bring surgeon, pathologists around the table, so to create a whole team to be able to treat and follow those patients. So the next step in Sherbrooke first is to finalize the lutetium and yttrium guidelines for the CNM, because I was mandated by the CNM to provide guidelines to create some policy on the special access program, or via a slightly open door on the orphan drug policy, but that's not clear if we can't use that door. I need also to finalize the Canadian-made Lu-DOTA-octreotate animal trials for biodistribution and dosimetry, submit that CTA to Health Canada, and switch the gallium to copper to be able to image across Canada. I need to conclude an agreement with the lutetium manufacturer to import directly into Canada and to certify in Canadian ground with the GMP rules in Canada to be able to use the lutetium into humans. So in conclusion, the somatostatin receptor-mediated treatment provides a feasible, widely well-tolerated therapeutic option for patients with neuroendocrine tumor, even for a very advanced case. The cure is rarely possible, but it's an excellent palliation treatment. The medial overall survival is between 3.5 to 6 years after the treatment, so that's very good. We prefer actually to do a protocol with low dose and more cycle to have less kidney and hematologic toxicity. And we need also to create very well standardized clinical trial to decide what is the best time for radioisotope in the treatment of those patients. And I will try as much as possible to bring Canada into the list of countries that will offer the state-of-the-art PET imaging in the treatment of neuroendocrine tumor. Thank you very much.
Thanks very much, Dr. Turcotte.